Good morning, I'm Rosalie, and today we'll discover new non-pharmacological pain therapies. Connect the links of mother's inflammation during pregnancy to her baby's brain development, and how to reduce fraud in Medicare while protecting identities of the beneficiaries, as well as new affordable healthcare options coming up. Millions of people on Medicare living in Alabama, Florida, Georgia, North Carolina, and South Carolina received new Medicare cards in the mail, as the Center for Medicare and Medicaid Services continues to send out cards to beneficiaries nationwide. Each new card will have a unique Medicare number instead of a Social Security number. Joining us this morning to discuss the new Medicare cards rollout throughout the nation is Angela Bryce Smith, the Regional Administrator for the Centers for Medicare and Medicaid Services, known as CMS. Good morning, Angela.
Good morning.
Medicare is a national health insurance program for Americans 65 and older. It also provides health insurance to younger people with a disability status. So as we approach open enrollment, how many Americans will be receiving Medicare this year?
Oh, we have approximately over 59 million beneficiaries nationwide and in the U.S. territories as well.
Wow, Angela, that's a lot of new cards. So why is Medicare mailing new cards?
Well, CMS, the Centers for Medicare and Medicaid Services, is committed to putting patients first. And as part of that, we want to ensure that we improve the consumer healthcare experience in Medicare, and part of that is about protecting them from identity theft associated with the use of a Social Security-based number health insurance card and removing that number and instead replacing that number with what we refer to as a Medicare beneficiary identifier number.
All right, so tell us what makes the new cards different from the old cards?
What's different? The numbers will be different. And when I say the numbers, what we're going from is what 9 digits with the typical Social Security number. We'll be going to 11, and they will also have intermingled we will be using alpha, ABC kind of numbers, as well as numeric numbers. So there'll be alpha and numeric, and there will be 11 of them instead of the 9 with the additional suffix that's currently in use. So it will be red, white, and blue, but it will be different.
So the new cards will help protect beneficiaries from identity and Medicare fraud?
That will help in preventing them from identity theft associated with the Social Security number.
So for those who are working in the healthcare field, how will the providers start to implement this new card into their systems? And will the beneficiaries need to use both cards during this transition?
Good question, because oftentimes people worry that they need still the old number and their provider won't know. We have been working with the provider community, the hospitals, the doctors, and all of the folks that provide services to our beneficiaries to be prepared for this new number and to be able to have the systems to adjust to have the new number embedded in them. And the other thing we've also done is to ensure that those providers have a way, secure way, to also look through our systems to be able to see what the beneficiary's new number is if by chance they don't have the card with them, or they forgot it, or they don't recall whether they had the card or not. So there is a way the beneficiaries can have some assurance that they will always be able to get the same coverage, the same benefits with Medicare, but their provider has also been looped in and informed about what that new Medicare card mailing should be, when it should be occurring, and to be prepared for that in their systems.
With all these new changes, will there be any changes in Medicare benefits?
The new card is not associated at all with any kind of change in coverage or change in the Medicare benefit. It's simply about preventing the identity theft that we know has occurred.
With all these new cards going out throughout the country, how can beneficiaries protect themselves from fraud?
Excellent point. The old card, once you receive your new card, what we really want you to do, the beneficiaries to do, is to properly dispose of the old card. And that doesn't mean recycle and just throw it in the trash. That means cut it up, shred it up, that sort of thing, to make sure that inappropriate people who may have access to your trash don't get a hold of it and misuse your card.
All right, so tell us where our viewers can find more information.
Feel free to certainly call 1-800-MEDICARE if you have any questions or concerns. Be aware that there are scam artists out there that may be asking for your number. They may ask or request that a fee be provided to expedite your card. All kinds of scams are going on like that. CMS would never do any of that uninvited, so feel free to be aware of that.
Thank you, Angela, for joining us this morning to introduce the benefits of the new Medicare card that will protect beneficiaries' identity.
Thank you.
Many healthcare professionals say the evolution of the Affordable Health Care Act has drove the cost of healthcare up instead of down. One of the newest models that is being promoted by some groups of physicians as an option for patients to save money and access quality healthcare at a more affordable cost is called Direct Primary Care, or DPC. This model offers primary care services at a fixed monthly fee in the form of a contract between a patient and a physician provider. The direct primary care model is now being offered in 24 states nationwide. Here to explain why this model of direct primary care will benefit those who have high deductible health insurance costs or no insurance at all is healthcare professional Joseph DeCapua. Good morning, Joseph.
Good morning, Rosalie. How are you doing?
I'm fine, thank you. So is direct primary care a form of insurance?
No, Rosalie. Direct primary care is not a form of insurance. There's a distinct difference between the two. One is health insurance, which is through a company, for example, Aetna, Humana, Coventry. That's health insurance where the plan offers all the services, medical services that you would need to be covered. Hospitalization, specialists, diagnostics, lab, rehab, pharmacy. So all those are covered underneath health insurance. Direct primary care is based on a membership format whereupon a patient and a doctor, primary care doctor, sits down and they contract services.
What is the distinction between healthcare insurance and direct primary care?
A hospital is not covered under direct primary care. The doctor offers a list of primary care services that the patient would receive for a fixed amount, monthly amount, which is usually between, depending on the age, $45 to $125 per month.
If a person cannot afford health insurance, will direct primary care provide services that most healthcare insurance policies offer?
Direct primary care only offers primary care services, and people have to remember that 70 to 80% of their medical needs can be met by a primary care physician. A hospital is not covered under direct primary care.
So if a person needed to visit the hospital, it would not be covered under direct primary care?
A patient that has health insurance can go to the ER if they want. Someone with direct primary care would call the doctor, and the doctor will then assess over the phone what could be done, whether the patient should go to an urgent care center or to the ER.
All right, now, Joseph, explain, how does the patient-doctor relationship work through direct primary care?
The patient comes in, they speak to the physician, they sit down, and the physician then takes out the contract, and they go over the services that are offered underneath this membership agreement. And when the patient decides that, yes, they want to become a member, they then sign up. Usually there's a processing fee. It depends, anywhere from $25 to $75, a one-time processing fee. And then there is the membership fee, that's a monthly fee. And again, that is age-related in age ranges. Most doctors do not see Medicare because they do not want to, what we call, opt out of the Medicare program. The program for direct primary care usually stops at people at age 64. One of the benefits of direct primary care for seniors is that usually when the spouse hits 65 and becomes Medicare eligible, that person's spouse does not have insurance and loses insurance. Using direct primary care, they're able to get some type of health care.
If a single mother with 3 children cannot afford health insurance for her family, is there a family plan membership available?
Yes, there is, and it depends on the direct primary care practice that you go to. Some practices have pediatricians or family physicians that would see newborns and up, but most of the practices for primary care have family practitioners that will see from 16 and up, or internal medicine doctors that will see from 18 and up. So the answer to that is it depends on the direct primary care practice itself.
Thank you, Joseph, for joining us this morning to share this new healthcare service model for those who need healthcare coverage and access to a primary care doctor.
Thank you, Rosalie. I appreciate it.
The National Institute on Mental Health funded researchers to connect the dots between inflammation in a pregnant human mother and possible effects on her child's developing brain. They linked high levels of maternal inflammation during pregnancy to reduced brain circuit communication and altered long-distance brain wiring at birth, to result in poor cognitive function by 1 year old and reduced impulse control and working memory at 2 years old. Research shows maternal inflammation is also implicated in some cases of autism spectrum disorder and attention deficit disorder. Researchers found clues in neuroimaging and measured blood levels of an inflammatory chemical called interleukin-6 in 84 pregnant mothers. Interleukin-6 is an active chemical in inflammation, and it's responsible for fever in autoimmune, infectious, and non-infectious disease. Though inflammation is a body's normal defense against environmental insults like infections, in addition to obesity, diet, drugs, smoking, maternal depression, poverty, and stress. But not all exposures cause harm. But inflammation in pregnant mothers is linked to mental disorders in their children. One of the researchers who linked inflammation in pregnant moms to their child's brain development is Dr. Claudia Buss of Charité University Medicine Berlin and the University of California, Irvine.
What has been acknowledged more and more is that it's really the very early environment and as early as the intrauterine environment that plays a fundamental role in determining disease susceptibility in an individual. And this has been supported, for example, by studies showing that maternal infection and inflammation during pregnancy actually increase the risk for psychopathology like schizophrenia, but also autism in the offspring. And what we are really interested in is what might be some of the biological determinants, so biological alterations during pregnancy that might be modifiable by interventions that program the fetal brain. We do this by recruiting women in very early pregnancy at the late first trimester and follow them up serially over the course of gestation to get measures of stress biology. So we're looking into inflammatory markers. So immune mediators that are elevated under conditions of infection, but also under conditions of stress, for example. We start assessing the infants right after birth. What we see is really the result of the prenatal environment and interaction, of course, with genetic susceptibility, and not yet confounded by postnatal influences. So we obtain an MRI scan shortly after birth, and we look at brain anatomy, but also structural and functional connectivity. And then we follow up the children further and do another MRI scan at 12 months and at 24 months of age to look at developmental trajectories. And then we also try to get a good estimate of the quality of the postnatal environment, which will also affect brain development because the brain stays highly plastic after birth as well, of course. Specifically, what we focused on was maternal interleukin-6 concentrations during pregnancy. This is a pro-inflammatory cytokine, an immune mediator that's, as I said, is elevated under conditions of infection and inflammation, but also under conditions of maternal obesity, for example, and also under conditions of maternal stress, which are all conditions that have been associated to an increased risk for psychopathology in the offspring. So we, for the first time, measured directly interleukin-6 in pregnant women and then related it to newborn brain maturity.
Dr. Buss explains what researchers found from the MRIs to determine how the brain is developing in the newborns.
So basically what we're doing is we're looking at activity in the newborn's brain. We're scanning them during natural sleep, and we're looking at which brain regions are active together. We're looking for synchronized activity. Two brain regions are active together, there must be some connection so they can talk to each other. So it's really based on the principle what wires together fires together. So we can really think about some of those conditions that we know can influence interleukin-6 concentrations during pregnancy, maternal depression, maternal stress, and maybe think of some multimodal interventions that affect these conditions and hopefully normalize interleukin-6 concentrations because it seems to affect fetal brain development. We still need to learn more about what kind of conditions during pregnancy actually are associated with alterations in interleukin-6 concentrations, and then to see whether if we modify those conditions, we also modify interleukin-6 concentrations. I don't think we are at the point where we would even want to start thinking about any kind of pharmacological intervention, because interleukin-6 is critically important for normal brain development as well. So we definitely wouldn't want to block it. So we still have to learn much more about what are levels where there seems to really be adverse outcomes on the fetal brain.
Researchers found that there can be some biological alterations during pregnancy that they may be able to modify through intervention if found early enough. Did you know over 100 million Americans suffer from chronic pain from an injury or trauma? If you experience moderate to severe pain that persists for 6 months or longer to recover, this condition is called complex regional pain syndrome, or CRPS. Here to introduce a non-pharmacological treatment for CRPS is Dr. Corey Hunter, an interventional pain specialist at the Ainsworth Institute of Pain Management and assistant clinical professor at Mount Sinai, along with Doug Rod, a patient and medically retired U.S. Army paratrooper who damaged both of his knees after years of active service. Good morning, gentlemen.
Good morning.
Good morning.
Dr. Hunter, although this is Pain Awareness Month, for those who suffer from chronic pain, this affects millions of Americans each and every day. So explain why chronic pain is so difficult to treat.
So that's a great question. Broadly speaking, chronic pain is any kind of pain that lasts for 6 to 8 months or longer. What makes it so hard to treat is once the pain's stuck around for that long, the pain may not necessarily be coming from the same place anymore. So what may have started out as something as simple as a sprained ankle or a broken arm, after 6 to 8 months, the pain may not be coming from the ankle or the arm anymore. It can move and it can migrate. And because we don't really have any way to pinpoint or where the pain is coming from, we don't really know where to focus the treatment, which makes it so hard to treat.
All right, define the difference between chronic pain and complex regional pain syndrome, and what patients are at risk for CRPS.
So the complex regional pain syndrome is a type of chronic pain, and it's probably the most severe that we see. We usually abbreviate it CRPS. And we don't know a heck of a lot about it insofar as like why some people get it and some people don't, and what causes it to keep going. It's something that not a lot of people know about unless you're unfortunate enough to have it or you know someone that has it. People who have it often call it the suicide disease because they would just rather not go on living another day than have to deal with this excruciating pain. It really starts out very simply as someone just having a really just a basic injury or going for routine surgery, and the body heals. But the pain just continues, and it just keeps getting worse and worse, and to the point where it spreads, and you can't even use the affected limb or body part anymore.
How is complex regional pain syndrome being treated up until now?
So up until now, CRPS hasn't really had a whole lot of treatments. We have basically some pain medications, nerve pain medications like gabapentin and Lyrica, which aren't really that effective. We have nerve blocks, which if they work at all, they don't tend to last that long. So because the pain is so excruciating in these patients, we tend to turn to opioids rather quickly just to give these patients some degree of some resemblance of relief. But because the pain is so severe in this particular group of patients, we really they need a lot more than the average patient to develop a tolerance very quickly, and then dependency tends to become an issue. Now we have the DRG stimulator from Abbott, which is really the first of its kind because for the first time we actually have a proven effective treatment for complex regional pain syndrome, and something that I can look my patient in the eye and tell them that there's a good chance I can give you your life back.
Speaking of patients, Doug.
Yes.
First of all, thank you for your service to our nation as an Army paratrooper. Tell us about your injuries and the chronic pain that you experience.
As you know, I as a paratrooper, you tend to take a certain amount of risks, I suppose, every time you're landing on the ground. But I had a number of injuries, subsequent surgeries, ended up with an early knee replacement. I was doing very well after the knee replacement, and then I was involved in a motor vehicle accident where someone ran a red light and just drove their car into the side of my car where that leg was. So that led to more surgeries, which actually put the leg back together, but I was left with a nerve that just would not settle down. And my leg was always swollen, sometimes very much so, to the point where I couldn't bend it. And I needed morphine just to get through the day, just to be able to function. And that's how this began with me.
Dr. Hunter, explain what is DRG therapy and how does it work? And is anyone with chronic pain a candidate for DRG therapy?
So Abbott's DRG stimulator works to reduce pain by sending small electrical impulses that you don't really feel to certain parts of the nervous system to alter the pain signals. And it's the first of its kind because what makes it so special is we're able to focus that relief to very specific body parts. So for someone like Doug, we can focus it on the knee, the foot. Let's say maybe you had an amputation like you were mentioning and you have post-amputee pain or phantom limb pain. We can use it for that. Groin pain. Someone may have had a hernia repair and they still have pain, or pelvic pain where someone can't sit down. So it works for focal nerve pain, and it sends these electrical signals very similar to what a cardiac pacemaker would do to help the heart beat correctly. We use it in a very similar way to basically fix those nerve signals for things like this.
So Doug, tell us, how was your CRPS being treated up until now?
Well, up to this point, we've done the pharmaceutical intervention. I have been on just about every type of medication that you can imagine. ultimately, my dependence on just morphine just to get through the day, that was everyday life. At the end of every day, I just sat on the couch with bags of ice on my leg to help get that swelling down. I also had a spinal cord stimulator implanted, which did help a bit in reducing the amount of morphine I needed to take, but it never took it away completely, not like the Abbott DRG stimulator did.
So now, Doug, you're on DRG therapy. How's it working for you?
Oh my gosh, life-changing is probably understated. After 10 years of taking morphine and fentanyl and all types of medication, I have not had pain medication since the second week of February. I've had this device implanted since the November of 17. I have, give you an example, my wife and I walked for 3 miles last night. Prior to having this device, I couldn't walk 300 yards.
Well, that is amazing. It's a miracle. It really is.
It is.
So, Dr. Hunter, how can DRG therapy potentially help others reduce their reliance on opiates?
We're in an opioid epidemic right now in this country because we have a reliance on opioids, and in particular in these patients, there was no choice. As a pain management doctor, we really try to avoid addictive medications as much as possible, and there's really two ways to go about that. That's intervention or prevention. In patients like Doug's case, it was intervention. We introduced something like Abbott's DRG stimulator to reduce the pain, or in his case, get rid of it completely. So now there's really no reason to be on opioid medication. And because it is so effective and because the statistics of it are so amazing, we feel comfortable offering it earlier to patients so we can potentially prevent them from being on opioids altogether.
All right, doctor, tell us where our viewers can learn more about DRG therapy.
So if you're suffering from chronic pain or you know someone suffering from complex regional pain syndrome, go to the website aboutyourpain.com. You can learn more about Abbott's DRG stimulator, see what kind of conditions we're using to treat with it, and more importantly, find a physician in your area or community that's trained in it. There's a physician finder there. You put in your zip code and you can find a physician that's an expert in DRG stimulation. Make an appointment, discuss it with the doctor, and see if this is right for you.
Wow, I am so excited to hear of this great news. Thank you both for joining us this morning to offer solutions to overcoming opioid use to treat chronic pain with a neurostimulation therapy.
Thank you very much.
Thanks for having us.
New medical innovations like non-pharmacological therapies can alter pain signals while reducing a patient's use of opiates. Researchers have linked maternal inflammation during pregnancy to a newborn child's brain development. And a new Medicare card will reduce fraud and protect beneficiaries from identity theft, while direct primary health care options help to offer affordable health care to all. Share with us how you and your family will benefit from new medical advances at facebook.com/Rose Lee Show. And follow us on Instagram at The Rose Lee Show. Watch this episode and many others 24/7 at RoseleeArcherShow.com. And thanks for joining us, and we do look forward to seeing you soon. The proceeding was a presentation for The Rose Lee Show. The views and opinions expressed in this program are not necessarily those of this station.